welcome back to another explainer. Today, we're taking some pretty complex medical data and turning it into a clear visual guide on GERD. That's Gastroesophageal Reflux Disease. We're going to take what usually just feels like this mysterious burning chest pain and reframe it. We're looking at it as a highly treatable, strictly mechanical plumbing issue. Seriously, if you've ever dealt with stubborn acid reflux, you know exactly how frustrating it can be. But by looking at your digestive tract like it's an intricate machine, well, we can figure out exactly why it malfunctions and, more importantly, exactly how to fix it.
So here's our roadmap for today. We're going to cover the actual mechanics of GERD, the triggers and risk factors, those major symptoms and red flags you absolutely cannot ignore, how doctors diagnose the damage, and finally, some comprehensive treatment strategies. Let's get right into it.
Starting off with part 1, the mechanics of GERD.
To really understand the problem here, we first need to look at the body as a machine, right? We need to see exactly how it's designed to process the fuel we give it. The absolutely crucial takeaway is that GERD isn't just some random heartburn. No, it's actually a structural failure of a vital one-way valve called the lower esophageal sphincter, or the LES. Think of this LES like a heavy-duty security door, located right where your esophagus meets your stomach. When you swallow, that door is supposed to swing open, let the food drop in, and then immediately slam shut. It locks all that powerful gastric acid and those digestive enzymes down below where they belong. But if you have GERD, well, that security door is compromised.
Let's look at how this mechanical breakdown actually happens. Step 1, food enters, and a muscular wave, called peristalsis, pushes it downward. In step 2, the LES relaxes just enough to let that food pass through. But step 3, this is where the malfunction hits. Instead of closing super tightly, like a submarine hatch after the food passes, a weakened LES just kind of stays ajar. And because your stomach is this highly pressurized environment filled with harsh hydrochloric acid and pepsin, that corrosive fluid just takes the path of least resistance. It splashes right back up into your totally unprotected esophagus.
Moving on to section 2, triggers and risk factors.
Okay, so now we know the gate is broken, but what's actually causing that malfunction in the first place? Well, surprisingly, your favorite late-night, high-fat snacks actually relax that security door on a chemical level. It's true. Things like chocolate, peppermint, and heavy caffeine intake literally contain compounds that actively reduce the muscle tone of your LES. Plus, eating really large, high-fat, or fried meals delays your stomach from emptying. That means the food just sits down there longer, churning around, creating way more acid, and essentially pushing up against that weakened door for hours. You combine that with a carbonated drink that fills your stomach with expanding gas, boom, you've just created the perfect storm for reflux.
But it's not just about diet. We also have to factor in physical realities and lifestyle risks. Conditions like obesity or pregnancy, for instance, put immense constant upward pressure on your abdomen. All that pressure forces the stomach and its acidic contents right up against that already struggling valve. Then there's a hiatal hernia, which is this really fascinating anatomical glitch, where a portion of the stomach actually bulges up through the diaphragm muscle. This completely destroys the mechanical support the diaphragm usually gives to the LES. Toss in chemical relaxants like smoking and alcohol, or even just a sedentary lifestyle, and wow, the whole system is put under incredible strain.
All right, let's look at section 3, symptoms and red flags. So, what are the warning signals your body sends when that acid escapes? You'd probably expect the classic chest burn, right behind your breastbone, sure. But GERD is actually a master of disguise. Because that corrosive acid is traveling upward, it can reach all the way to your vocal cords, your throat, and even your mouth. No joke. This completely explains those surprising symptoms like chronic hoarseness, a persistent dry cough, or even sudden asthma symptoms. In fact, dentists are often the very first people to spot GERD, because the silent reflux of acid at night causes severe dental erosion on the back of your teeth. Crazy, right?
Now, we need to pause here, because it is absolutely crucial to distinguish between a GERD flare-up and a cardiac event. A lot of folks actually confuse severe GERD with a heart attack. GERD chest pain is typically a burning sensation that moves upward. It usually gets worse after meals or flares up the second you lie down flat, and it's often accompanied by a sour taste in your mouth. A heart attack, on the other hand, is completely different. That's characterized by a crushing, squeezing pressure that often radiates out to your left arm or your jaw, and it comes with shortness of breath and cold sweats. Please never ignore crushing pressure or radiating pain by just assuming it's yesterday's spicy dinner. While everyday heartburn is definitely manageable, there are some strict red flag medical emergencies you need to know about. If your internal alarms ever trigger any of these, like vomiting blood, Noticing black, tar-like stools or experiencing unexplained weight loss, you need to seek medical help immediately. One of the most alarming mechanical failures is dysphagia, which is when food physically gets stuck in your esophagus on the way down. This usually means the acid has burned the tissue so badly that severe scar tissue, or a stricture, has formed and narrowed the tube. That is a serious mechanical emergency.
Which brings us to Section 4, Diagnosis and Complications.
If you just leave this unaddressed, that persistent chemical burn inside your chest creates a cascading timeline of cellular damage. Over a period of months, repeated exposure leads to erosive esophagitis. That's visible, highly painful inflammation and ulcers. Fast forward a few years, and a really fascinating but super dangerous mutation happens. Your body, desperately trying to protect itself from the stomach acid, actually changes the cells of your lower esophagus to resemble the acid-resistant cells of your intestines. It's called Barrett's esophagus. And look, while it's a clever survival mechanism in the short term, those mutated cells are precancerous. Over decades, this can tragically lead to esophageal adenocarcinoma, which is a very serious form of cancer.
Obviously, we want to stop that timeline right in its tracks. To do that, doctors kind of have to play detective. They'll use an upper GI endoscopy, basically dropping a tiny camera down your throat to visually inspect the damage. But the true gold standard for tracking the actual acid, that's a 24-hour esophageal pH monitoring test. They place a tiny sensor in the esophagus to measure the exact chemical acidity over a full day and night. And if they suspect that security door itself is totally busted, they'll use Esophageal Manometry to physically measure the muscle strength and the actual group of that valve when you swallow.
Finally, let's talk solutions. In Section 5, Comprehensive Treatment Strategies.
The good news here is that because this is primarily a mechanical and chemical problem, we have highly effective, proven ways to repair and manage the whole system. The most successful management plans rely on layering your defenses. On the lifestyle side, we literally use simple physics. By elevating the head of your bed to 6 to 8 inches, you use gravity to keep the acid trapped in your stomach while you sleep. You also want to avoid lying down for 2 to 3 hours after eating. Then, on the medical side, we bring in the heavy artillery. Antacids are great for quick temporary relief, sure, but the long-term heavy lifters are proton pump inhibitors, or PPIs, like omeprazole. These meds go straight to the root of the chemical issue. They actually shut down the microscopic acid punks in your stomach lining, which gives your esophagus the completely acid-free environment it desperately needs to heal. But what if that valve has completely structurally failed, and medications just aren't cutting it? Well, surgeons can step in and physically reinforce the broken valve. One really cool modern method is the LINX device. It's basically a flexible ring of tiny magnetic beads surgically wrapped around the outside of the esophagus. The magnets are strong enough to keep the door shut against stomach pressure, but they yield and open up when the downward force of a swallowed bite of food comes through. Pretty brilliant, right? The classic surgical gold standard, though, is the laparoscopy Nissen Fundoplication. Here, surgeons cleverly wrap the top part of the stomach all the way around the lower esophagus. They literally use the stomach's own bulk to recreate a tight, high-pressure seal.
Now here is a highly underutilized but super effective tool in the arsenal: physical therapy. Because your diaphragm muscle wraps right around and supports the lower esophageal sphincter, you can actually leverage targeted diaphragmatic breathing exercises to strengthen that muscle. It naturally pulls that security door more tightly shut. Physiotherapists can also work with you on postural correction. Just slouching dramatically increases your abdominal pressure, which forces acid up. Fixing your posture and adding in some moderate aerobic exercise for weight management creates an environment where your digestive mechanics can actually function the way they were designed to.
So, this brings us to the ultimate question everybody asks when their internal machinery starts breaking down. Can this ever be permanently cured? Well, the short answer is that while GERD is technically considered a chronic condition, cured might not be the exact right word. Controlled is a much better way to look at it. With the right combination of structural reinforcement, lifestyle adaptation, and medication, patients can absolutely achieve complete long-term symptom relief and completely stop the progression of cellular damage right in its tracks. While most folks do achieve really excellent control using the lifestyle, medical, and surgical tools we've explored today, I want to leave you with one final, kind of provocative thought to ponder before you reach for your next late-night snack. Your digestive system is a high-performance machine. It runs 24 hours a day, 7 days a week, with absolutely zero breaks. So, are you giving it the right fuel and maintaining the right physical mechanics to keep that acid exactly where it belongs? Or are you unwittingly forcing the machine to tear itself apart from the inside out? Think about that the next time you feel the burn.
Until next time, keep learning and please keep taking care of your complex machinery.